below where you can see down to the top of the larynx, that's what we call the laryngenopharynx. Okay? And that does represent the last part of the shared passageway. Because at the end of the laryngenopharynx, you have only two options. If you are food and drink, you should be heading at that point into the esophagus. If you are air, that's where you should be making the turn to go into the larynx. So again, we see nasopharynx, oropharynx, laryngenopharynx. As far as air that is going from the laryngenopharynx into the larynx, remember that that's the transition between the upper down into the lower respiratory system. Remember that the air itself will go through the slit or opening called the glottis at the top of the larynx. Here's a nice set of pictures kind of showing you the structures here of the larynx. Remember the larynx, this thing right here that we commonly call the voice box. Remember that's what you guys would have gotten out of the cat, right? It's that cartilage box right here. Okay, remember at the very top there was a slit called the glottis and a little tongue-like flap called the epiglottis. Okay, the idea with this larynx is its most important function is simply protecting the entrance of the lower respiratory system. In other words, ensuring that when you have food and drink passaging through the area, that food and drink does not get into the larynx itself. Okay? In other words, when you do something like swallowing, that we can close off the passageway. That's the most important part. As far as structures go, okay, it turns out that there are three major pieces of cartilage that we'll focus on. There are other pieces. We're just not going to worry about them. The three large pieces we're going to concern ourselves with are the thyroid cartilage, the cricoid cartilage, and the epiglottis. Now, of the three, I know you already know the epiglottis, but just to point out the other two, this is the large thyroid cartilage. You can see that it covers the front and the side, but not the back. The cricoid cartilage, this one is actually going to go all the way around, and it serves as a junction between larynx and trachea. All right. As far as overall role, thyroid cartilage, and to some degree the cricoid cartilage, they're there to provide kind of external structure, anchor points, so that we can hang the internal portions of the larynx. Okay, they're also there to ensure, at least in part, that you cannot deform or lose the air passageway. Okay, so in other words, that we can hold it open to ensure that airflow can occur. Again, it is one of those things that when it comes to this functionality of the larynx, one of the biggest things is that if you were to swallow food and drink, that we can prevent it from getting into the larynx. Okay, when you swallow, remember we are going to have muscles that pull the larynx upwards. And as they pull the larynx upwards, it will force the epiglottis to cover the glottis. As we'll also talk about in a minute, the idea is that we can also close the glottis. And between the epiglottis coming down on top and the glottis being closed, that usually is sufficient to keep food and drink from being able to come down and enter into that lower respiratory system.
It's wonderful. That's wonderful. You know how stuff works.
Yeah.
I had to think about it.
No, I know.
Wonderful.
And it's definitely one of those things that when it doesn't work, an issue. All right, here's just a picture showing that larynx from the top. Here's the epiglottis, that little tongue-like flap. Again, remember, if you were to actually swallow and the larynx raises up, this would be forced down on top of the glottis. Okay, now, as far as the glottis goes, remember the glottis is actually a negative thing. It is the opening, the hole. Here the glottis is there and present. Here the glottis seems to have disappeared. The idea is that in this case, since the glottis is there, air can move through the larynx and get down into the lungs and back out. Whereas in this case, with the glottis closed, nothing can get through. Okay? It means no air, but it also means no food and drink. just another picture showing you the real thing. Okay, again, epiglottis, glottis. What they also mention here, though, in this picture, are the folds that are near the glottis. Turns out that inside of the soft tissues that you would see on the top, you are going to have an important set, or two important pairs of ligaments. There is what's called a vestibular ligament, and a vocal ligament. All right. The thing about both of these ligaments is if you were to look on top of the larynx, you wouldn't be able to see that ligament by itself because each of them is covered by soft tissue. The combination of ligament and soft tissue is what we would call a fold. So you have a vestibular fold and a vocal fold. That vocal fold you may have heard better as a vocal cord. Essentially, they're synonymous terms. If you look at the way these guys are arranged, what we actually see is that on the superiormost surface, we have the vestibular fold. Underneath that is where the vocal fold is located. Okay, so it's one on top of the other. All right, the purpose of the vestibular fold is simply protection. This is what will close when we swallow so that you can prevent the entry of food and drink. The vocal fold, this one, the one that we want to protect by having it underneath the vestibular one, this is the one that we can actually use to produce sound. So the idea with this is simply that if the glottis is open, so if the vestibular fold is open and we've got it out of the way, air passing through and between the two vocal folds will cause it to vibrate. And that vibration is what we produce as sound. All right. Now, the thing about this sound is that it can be varied based upon how much tension do we put on the vocal fold. Okay. Some of the cartilage we did not talk about is actually going to be attached to this vocal ligament inside the fold. And there are a series of muscles that can pull on the cartilage and therefore change the tension on the vocal fold. Okay, it's a lot like a rubber band in that if you stretch the vocal fold or the rubber band really tight and cause it to vibrate, so strum that rubber band, you will get a high frequency sound. And remember, humans interpret that as high pitch. If you basically don't stretch it as much, allow it to be a little bit slacker, okay, and then strum the rubber band or the vocal fold, what you'll get is a much lower frequency or much lower pitch. Okay? So part of what we can do is we can simply adjust how much tension is the vocal fold when that air is moving past. The thing about that sound that we're producing, though, is that is the sound of phonation. Okay, phonation is basically raw sound. Okay, I'm not going to do it because I just can't do it justice. But if you've ever heard the Tibetan throat singers, they're like oh sort of deal. Okay, that's pure phonation, right? That's pure phonation. That's just a pure raw sound coming from the vocal folds, and that's it. That's all they're doing. And if they change notes, it's simply by having the vocal folds change the amount of tension that they're under. Okay, now having said that, what most of us do is not rely just on phonation. That would be a funny lecture, wouldn't it? Instead, most of us articulated the phonated sound. So in other words, I don't rely just on the tension on my vocal folds. Right now, I am also manipulating that sound with my tongue, with the position of my lips, the distance that my oral cavities top and bottom are from each other. Okay, a set of things to try to alter that sound so that it comes out in a way that you would recognize. Okay, bottom line, sound produced by the larynx is phonation. How you then manipulate it through the use of other structures, that's articulation. And most of us do both of those. It is worth noting that what this then means as far as the larynx goes is that you're going to have some muscle that is going to be involuntary. Okay, a lot of reflexes associated with the swallowing. So for instance, the muscle that closes the vestibular folds, okay, the idea is that's going to be reflexive. Okay, the idea that you've swallowed, so you need to make sure you get contraction to cover the glottis so that you don't have that opening. The musculature that's associated with the vocal folds, though, is purely voluntary. Okay, the idea being that you are choosing when to make those contractions so that you can change the phonated sound to match what you're trying to achieve. All right, continuing on down, inferior to the larynx is the trachea. The trachea is, for the most part, just a conveyance, just a matter of getting air from larynx down towards the lungs. It is actually going to end before you hit the lungs, though. It basically branches into a right and left pulmonary bronchi. That's what it looks like. So right below the cricoid cartilage, so right before you split, that is the trachea. The most prominent feature of the trachea will be these cartilage rings, so tracheal cartilages. It's variable. Some people have as many as 20. Some people have as few as 15. What is important is that you simply have enough that you can maintain the open structure. Okay? That's what that cartilage is really there for, to ensure that the windpipe, which is what we commonly call the trachea, stays open, and therefore your air passageway is unobstructed. As far as the endpoints, the trachea does end at those primary bronchi. The idea is that there is one of those for each lung. And if you look at the relative size and angle of those bronchi, there is a difference. The right just happens to be much larger in diameter, and it happens to go down at a steeper angle. To explain the larger diameter, it's simple. Your right lung is bigger than your left lung. Because in humans, the heart, the other major occupant of the thoracic cavity, is offset to the left. So there simply is less space for lung on the left and more space for lung on the right. So if you've got more lung over on the right side, you need a bigger tube getting more air over there. All right. As far as the angle, part of that is simply the accommodation around the heart to get to that left lung versus the right. But it is worth noting that because you do have a steeper angle, if people aspirate, there you go. If people aspirate material, it tends to be on the right side because the steeper angle means that it's more likely it'll end up in the right lung than the left. Okay, so that is something that's a very commonly clinical scene. Yes?
Because if the left lung get infected, it's more serious, right? Because there's not that much of it. You think that's something?
Well, as it turns out, the idea is if you lose the entirety of the left lung, you have lost less total respiratory capacity than if you use the right. Now, having said that, the left lung is what surrounds the heart as far as it's packaged on that same side. Now, there is all of the serous membranes and stuff, but yeah, you would worry if you had an infection in your left lung that maybe that would lead to infection in other structures there, which would include the heart. So it is one of those things that in either case it would be serious, yes. Okay. Before we actually get to the bronchi, though, I did want to come back to one aspect of the trachea, simply because it is an important thing about the trachea that you recognize, which is that, as visualized in this picture, the cartilage rings are not continuous. Okay, what happens is that effectively these guys look like U's, where they are longer in an anterior-posterior direction than they are wider. And the reason for it is simple. We need a tube behind the trachea to be able to impinge on its space. What runs behind the trachea is the esophagus. And occasionally humans will swallow boluses of food that are bigger than what the esophagus can easily accommodate. I'm going to imagine that everybody has made that mistake at least once, where you swallow something and it kind of hurts going down. It's like way too big. But, at that point, what are you going to do, right? All right, so the idea is that if you had nothing but a solid cartilage ring, that bolus would come down, it would get stuck on one of those pieces of cartilage, and you would be in a bad way, because at this point, your digestive system would be blocked off. Would you expire immediately? No, but can you live without a digestive system? Not easily, right? Because that's what provides you your nutrition. But here's what happens instead. If you swallow that too big bolus, the esophagus can actually push on the back of the trachea on an elastic muscle that's there in the back. And the idea is that it can actually push into the airspace. Okay, so that entire structure pushes down. But because the cartilage is much longer in the anterior posterior plane than wider, it can never actually push so far that it cuts off the airway. Okay? So in other words, it can go part of the way, but not all of the way. Right? And the nice thing is, of course, that bolus doesn't stop. It keeps on moving until it reaches the stomach, right? So that's a temporary measure. But even in that temporary state, it cannot close off the passageway. All right. While we're still on this picture, though, here are those bronchi. Here you can see the right side definitely larger in diameter than the left. That's because the right lung is much bigger than the left lung. And the idea is it is at a slightly steeper angle. Again, part of that's just to accommodate the heart, which is going to sit right in here. And part of that's also just to because of the relative distance that we have to travel to reach the lung. Now, as far as the bronchi go, when they get to the lung, they are going to enter a section of the lung that's called the hilus. Okay, hilus by now should seem like a very common term. Hilum, is basically going to be where you have a single doorway into an organ. So we talked about a hilus on a lymph node. In 165, when you guys did the kidney, you would have talked about the hilus of the kidney. We have, similar here, a hilus on our lung. The idea here is that this is the single area where we're going to move all of our plumbing through. That includes that primary bronchi, but please do note that it also includes lots of blood vessels. All of those pulmonary pieces, so the pulmonary artery going in and the pulmonary veins coming out. By the way, which color is the pulmonary artery?
Red.
It's the blue one, right? Yeah, remember, and the pulmonary system is reversed, right? Because we are taking deoxygenated blood away from the heart to the lungs to pick up the oxygen that's brought back by those red pulmonary veins. Okay? Anyway, bottom line, that's that single connecting point. Not pictured, but also present would be things like lymphatic vessels, nerves. Okay? Any plumbing piece that needs to get to the interior of the lung is going to be routed through this hilus. All right. Now, because this is going to have a huge amount of plumbing pieces, the connective tissue in the area effectively helps to stabilize not only the plumbing, but the entire lung structure itself. So that's why we talk about all of the connective tissue here that holds that plumbing as forming the roots of the lung. Because this is the one area where we are truly securing it in place. Which means that if the lung expands, it can expand everywhere except here. If the lung shrinks, it can shrink everywhere but here. This is the one spot where we have firmly tied it into a structure. Again, humans, we do have two lungs, the left and the right. Already mentioned it, but we'll see it in a second. There is a size difference. As far as each of these lungs go, they do have a base portion that does rest on the bottom of the pleural cavity on the diaphragm. Okay, I know it says rest on the diaphragm, but just remember there is a pleural cavity there. So it's not directly on the muscle, but rather it rests on the pleura, and the pleura in turn rests on the diaphragm. The thing about our lungs is that they are like the cat, at least so far as that they are broken up into lobes. Okay, the idea is that each lung will have a particular number of lobes. For instance, on the right side, since it is a bigger lung, it's got more lobes, 3. And as you can see, opposite that, the left lung, since it is slightly smaller in size, it's only got 2 lobes. That does make it different than the cat. And the cat had an equal number of lobes on both sides. Here in the human, 3 on the right, 2 on the left. So again, superior, inferior lobes on the left, separated by the oblique fissure. As far as the why, just this nice picture showing and illustrating why you can have 3 lobes on the right but not the left. Here you can see the offset nature of the heart, which simply leaves less room on the left than is there on the right. Okay, so you simply have more space for a bigger lung with more lobes on that right side. All right. Now at this point, we need to start thinking about not the exterior of the lung, but rather what goes on the interior. So the actual air passageways. Okay, now the idea with all of those air passageways is that we are going to refer to them as the bronchial tree. And the picture that you're given is basically the bonsai version of this bronchial tree. Now, bonsai trees are those little trees that you clip to make the particular shape, and usually you clip a lot of it away. And that's exactly what's going on here. In a real lung, this should look much more like a bush or a hedge, where there are just all sorts of tiny branches attached to bigger branches or whatnot. What they've done in this picture is they've taken that and they've cut like 98% of it away so that you can see just one example of the different types of tubes that are there. Okay, the idea is simply take what you see here and magnify the number of, especially these guys, by at least 100, if not like 1,000-fold, just for one section of the lung. Okay, so they trimmed it a lot just to show you and make it cleaner and nicer to look at. Bottom line, though, is that we could say that this is at least one part of the bronchial tree. Now, when it comes to the bronchial tree, the trunk of the tree is that primary bronchi. But the thing about this primary bronchi is that it is a piece of tubing that is part in and part out of the lung. The part that is going from trachea to where you hit the hilus is the part that we would call the extrapulmonary bronchi, simply because it's the one part that is outside of the lung. As soon as you get into the lung, so from the primary bronchi and all of the other branching that happens, all the way down to the alveoli, all of those would be the interpulmonary bronchi. Okay. Now what happens when you get in the lungs is basically that the primary bronchi is going to split into secondary bronchi. Okay, turns out that you will end up with a secondary bronchi for each lobe. So if I'm thinking about the right lung, where the right pulmonary bronchi enters into the right lung, how many secondary bronchi should I have in that right lung? 3. I've got 3 lobes. I should have 3 secondary bronchi. And on the left side, my one primary bronchi will turn into 2 secondary bronchi because I have 2 lobes. All right. So in other words, this is the left side, and they are showing that primary bronchi going in. By the way, where they say root of the lung, that's basically the hilus where we are entering in. So that portion would be the extrapulmonary. From here down would be the intrapulmonary. Notice that when the primary bronchi does split, it splits into two secondary bronchi. One they kind of cut short, the other one is the one that they're going forward with. The thing about the secondary bronchi is when they get to their individual lobe, they in turn will split into tertiary bronchi, and each tertiary bronchi will feed a section of a lobe called a bronchiopulmonary segment. As it turns out, the number of segments per lobe is variable, so that in total, on the right side, you will have in those three lobes a grand total of 10 segments. So therefore, 10 tertiary bronchi. On the left side, there's a bit of variation. Some people have 8 bronchiopulmonary segments. Some people have 9. Either way, you got to fit them within the 2 lobes that are there, which means that if you have 8 segments, you've got to have 8 tertiary bronchi. If you've got 9, you could have 9 tertiary bronchi. The thing about the primary to secondary to tertiary bronchi is that 2 things, and they are related, are going to be happening. One, the size of your tube is shrinking. A primary bronchi has to be big enough to supply all of the air to an entire lung, whereas the secondary bronchi is just to a single lobe, and a tertiary bronchi just to a bronchiopulmonary segment. So you can get away with smaller and smaller tubes. Because the size of the tube is shrinking, you actually need less cartilage to hold its shape. So there's a lot of cartilage in a primary bronchi, but as you go into the secondary and tertiary bronchi, there's less and less cartilage. Less cartilage leaves room for more and more smooth muscle. Now, the smooth muscle does 2 things. One, it helps to provide some structural integrity. That muscle being in the wall helps to hold its shape. But it also starts to give you the ability to control the diameter of that vessel, okay, that tube, and therefore, potentially, the amount of ease through which air can flow through. All right, now, it is worth noting that the amount of adjustments that we can do are still going to be relatively limited in the tertiary bronchi. This is a tertiary bronchi. You can see that there is a lot less cartilage here than there is in the primary. Notice that's complete rings. You can't constrict that. There's a ring of cartilage that's going to keep the diameter of that tube the same. Here, though, these little bitty fragments, they do help keep the tube from collapsing, but you'll notice there is some distance that the smooth muscle could pull those guys together, shrink the tube a little bit. Okay, the thing is, though, the amount of change you can do here is relatively limited. You can change the size, but not as much as you can further on. Because as it happens, when you leave the tertiary bronchi and enter into the bronchioles, these are tubes that, yeah, they may start off with a little bit of cartilage, but will become more and more dominated by smooth muscle. So when you get to the bronchioles, that's where you can have the greatest effect on the diameter of the tube and therefore the ease of airflow. All right. Now, as far as the bronchioles go, the idea is that you're going to have a series of different types of bronchioles, but the last section of these bronchioles is going to be the terminal bronchioles. And the interesting thing about these guys, for every tertiary bronchi that you have, remember that's what goes into a bronchiopulmonary segment, you're going to have roughly on the order of about 6,500 terminal bronchioles. So in other words, When you leave the bronchi and go to bronchioles, that's where you do most of your dividing into smaller and smaller and smaller tubes. In other words, when you go from that guy, tertiary bronchi, into the bronchioles, this is where you do a lot of your division. These are the tiny twigs on the tree. And there's a lot of twigs for those big branches. The idea where we see terminal bronchial, by the way, is also an important one to note, because terminal bronchial represents the terminal portion of the conducting portion. Okay? So it's the last part of the conducting portion, because the next tube is labeled respiratory bronchial. It's called that because it's the beginning of the respiratory portion, because that's the area where you can start to move the oxygen and CO2 through the walls. In either case, though, it is important to recognize that all of the bronchioles, whether they're in the conducting or respiratory, they are going to have very limited amounts of cartilage, if at any. Okay? And the idea is they're mostly held open by their small size and the smooth muscle that's there. That does mean that they can be altered by the contractile state of the smooth muscle. The idea is what we tend to see is a control by the autonomic nervous system, so think parasympathetic and sympathetic system, helping to control the amount of contraction and therefore helping to control airflow. Ma'am, was that a question? Yeah.
The left lung, is it weaker than the right lung when it has air on?
It's not, no. It's not necessarily any weaker. There's just less of it. So if you were to lose a lung, if you lose the left lung, you are